with the development of arthroscopy and with the improvements in MRI, shoulder surgeons nowadays know that there are many types of rotator cuff lesions, and when we consider partial lesions, we can have three different situations: articular lesions, the so-called PESTA lesions, bursal lesions, and interstitial lesions too. Interstitial lesions are the less common type of partial rotator cuff tears, and this is what this case is about. So this case is about a 50-year-old truck driver, a very hard worker, who started to have pain over his right shoulder about 6 months ago. His MRI revealed an interstitial supraspinatus lesion, and he had also a very painful AC degenerative arthritis too. So we tried conservative management with an injection, both in subacromial space and in his AC joint, with physical therapy for about 4 months with absolutely no results. And then finally an arthroscopy was indicated to evaluate and probably fix his rotator cuff partial tear and to perform a Mumford procedure too. So this is his arthroscopy. Now we are seeing a right shoulder. We're establishing the anterior portal using a spinal needle and then opening the capsule with a hemostat and a mosquito. Now we are palpating the biceps anchor. This is not a slab, just a degenerative condition. And his biceps, when we probed it, it was in a very nice state too. So then when we looked in the articular part of the lesion, we saw the lesion, and then we decided to mark it with a proline passing through a spinal needle. And after that, we went to the subacromial space. So now we are working for the lateral portal, watching for the posterior portal, removing all the bursitis and the synovitis until we found the acromion. Now we are cleaning the lateral gutter, which in my opinion is a very important step to see the subacromial space. Now we are seeing the anterolateral aspect of the acromion, and for the lateral portal, we are performing a very slight and simple acromioplasty. Now the acromioplasty is finished, and then we move the portal. Now we are watching for the lateral portal. This is the acromion, and now with a spinal needle, we are establishing an anterosupralateral portal. Now for the anterosupralateral portal, we are cleaning the tip of the acromion just to see the acromioplasty. That was fine, and then we started look at the tendon. So now we are looking at the posterior superior cuff. Now we are seeing our proline to mark the lesion. And then we started to ablate the superior fibers and to palpate with the ablator the posterior superior cuff. And at that moment, we decided that there was no reason to complete that lesion, but since that patient was very symptomatic, we decided to perform a rotator cuff reinforcement. So now we are seeing the greater torosity. We are preparing a very small bony bed just to put one anchor. Now we are putting the hole. We are using the anchor guide, and now we are introducing a 5.0 absorbable double-loaded anchor. And once the anchor was in place, using for the anterior portal, using a simple bird beak, we passed the first suture, the white one, in a retrograde fashion through the anterior part of the posterior superior cuff. This is what we are doing now. And then we perform the first knot, a sliding Duncan knot. Now we are putting a lot of compression, as we can see on the video. And once the knot was tied, we would just have to cut it. And then for the posterior portal, in a retrograde fashion too, we passed another bird beak for the infraspinatus and passed the second suture in a retrograde fashion too. Then the knot was done, and this is the final construct in which we can see that a very strong reinforcement was performed in the posterior superior cuff. So then we would have to perform the Mumford procedure. Now we are working for the anterior portal. Now we are removing the inferior part of the very distal clavicle, and now we can see that the inferior part has been removed, but not the superior part. At this moment, I always like to pass a Kirschner wire that's going to guide me to enter in the posterior part of the AC joint. So now we are removing the camera from the lateral portal when entering in the AC joint through a new posterior portal. Now we are seeing the clavicle on the left, the acromion on the right. For the anterior portal, we are removing the capsule with electrocautery, and after that we are using the burr to remove the anterior superior parts of the distal clavicle. Now we are seeing that almost all bony part that was removed, and then we moved the portals, and now we are watching the AC joint through the anterior portal, clavicle on the right, acromion on the left, still some bone to remove in the posterior superior parts of the distal clavicle. Now we are removing it through the new posterior portal. And now the surgery was just finished, when we can see that a very good space was created. This is what the Mumford surgery is about.